This Week in Virology, the podcast about viruses, the kind that make you sick. From Microbe TV, this is TWiV, This Week in Virology, episode 1206, recorded on April 3rd, 2025. I'm Vincent Racaniello, and you're listening to the podcast all about viruses. Joining me today from New York, Daniel Griffin.
Hello, everyone.
It's a nice bow tie. I like the colors.
It's my fungal bow tie.
Okay.
Apparently, the WHO is sharing that we are maybe neglecting fungal diseases, surveillance, therapeutics, and the rest. So,
what do you think about that?
It's true, actually. Yeah, I think I always find this when Sarah and I do the infectious disease podcast. There's always a shortage of articles on fungal disease. So
I thought mostly immunocompromised people get fungal diseases.
So it is a problem in immunocompromised, but also what we're realizing is a lot of what we learned about fungal disease, being uncommon, only being in certain clusters. Yeah. Can you imagine is not actually correct? Some recent studies where they're looking at coccidioidomycosis down in the Southwest U.S. Something like 10 to 20% of people coming in with community-acquired pneumonia. If you actually really look, it's cocci. It's not bacteria. It's not viruses. So
really.
Yeah. But again, if you don't look, guess what? You'll never get a positive test.
But can you treat them?
Well, that's the big thing is you don't need to in most cases. The recent guidance was hands in the pockets, which I was talking about on rounds today was my recommendation for
hands in the pockets. What does that mean? Take money?
No. Just put your hands, keep them in your pockets, and don't mess.
I got it. Okay.
Yeah. All right. So let's jump right into it. I am almost done with John Green's Everything is Tuberculosis book. And so I have a quotation. Biology has no moral compass. It does not punish the evil and reward the good. It doesn't even know about evil and good. Stigma is a way of saying you deserve to have this happen. But implied within the stigma is also, and I don't deserve it, so I don't need to worry about it happening to me.
So do you like this book?
I really do. And it is funny. I was joking with my wife and daughter about how when my wife first met me, I was much like John Green. As every conversation, I was like, well, this is really because of tuberculosis. And did you know he died of tuberculosis? And so I said to Daisy, I said, when, I met your mom, I was still in my everything is tuberculosis phase. And my wife said to me, and at some point, did that end? I'm not aware of that. Is it still your favorite disease? And I was like, oh my gosh. This is what I cut my teeth on, Vince. And my time at, in medical school at Bellevue, I was doing research on tuberculosis, and that's what brought me out to Utah. And so, tuberculosis is still one of my diseases that I find most mysterious, interesting.
Well, this guy does he's on a book tour. He's all over the place. Wow.
Yeah, he's a podcaster. That's how I actually got to know John Green is he does these AP US history podcasts, YouTube things. He's a great writer, very engaging, very good speaker. And actually the audiobook is narrated by him. So it's worth the 5 hours or for me at 2X, the 2.5 hours. Okay. So, all right, well, let's jump into it because I think like one of the things that I'm worried about, and this is why I put this in here, is that we have sort of lost 130 years. We've gone back to this pre-Coke, pre-Pasteur. Diseases are not caused by germs; they're caused by your constitution, your bad choices. Sort of back to blaming the patient. Instead of actually, realizing that a person who gets sick is a victim of this infection. So we will start off with measles, where there has been a lot of blaming of the victims. I really still upset by when they talked about the child dying. The fact that somebody who shall not be named, because they've been named way too much, actually said, there may have been an issue of malnutrition. Well, I hope you said that to the parent when you were talking to them, because that is not really the case in the U.S. with most of the people getting sick with measles.
The problem, Daniel, I have is lies all the time.
Yeah.
It's it's just intolerable.
Yeah.
People are starting to call for his resignation.
Well, I'm glad because, I mean, it's just how many hundreds of people need to be sick before we say this was a mistake. So, all right. So I'm going to start off with the CDC buried a measles forecast that stressed the need for vaccinations. Leaders at the Centers for Disease Control and Prevention ordered staff this past week, not to release their experts' assessment that found the risk of catching measles is high in areas near outbreaks where vaccination rates are lagging, according to internal records reviewed by ProPublica. In an aborted plan to roll out the news, the agency would have emphasized the importance of vaccinating people against a highly contagious and potentially deadly disease that has spread to 19 states. And so, here we have the CDC being muzzled. We have experts, doing what the CDC has done for decades, trying to make recommendation. And here the staff was ordered not to release this information, not to release.
I went to look at this article and someone asked them why, and they said, "Oh, people already know this. We don't need to tell them." Isn't it the most inane explanation you ever heard?
It's dishonest. It's disingenuous.
It's dishonest. Yes.
Yeah. This is a time when you remind people, you talk about vaccines, you enter into, as the CDC, that discussion about the risk and benefit, the tremendous improved outcomes with vaccination over getting the disease, the immune amnesia, the 20% ending up in the hospital, the 1 in 1,000 children dying. This is when you enter that space and you don't leave a vacuum for, the anti-science snake oil salesmen, the people trying to sell people stuff who are willing to take that blood money. And that's not political. That's just the honest science of what we're seeing here. So. And how are we doing? Not well. So we'll start off with the we are only getting updates once a week from the CDC. So this last update was from March 28th. So that's up until noon on Thursday. We get the update on Friday. As of March 27th at noon, a total of 483 confirmed measles cases in the United States reported by 20 jurisdictions. So measles is all over the place. By now, we're over 500. And as I mentioned, we have, of those 483 confirmed, 70 have ended up hospitalized, not for quarantine purposes, just that was a straight out lie. These are sick kids struggling to breathe. And a quarter of these folks are under 5 years of age. These are tiny little children that are in the hospital because they are being preyed upon by people that are willing to lie. Measles cases by rash onset, sort of showing what's happened over time. You really see we have this huge, huge peak, and then David can put this up where people can actually look at the map and see really the big hotspot is Texas, but we're seeing cases all around New Mexico, California, up there in Washington, Alaska, down the southeast, Georgia, Florida, Kentucky, Tennessee, Ohio, Michigan, Minnesota, Pennsylvania, New Jersey, New York, Vermont, all over the place. Even Rhode Island's got a number of cases. So all over the country. And you can actually compare this to a map of percent vaccinated, right? We really want a country where 95% of folks are vaccinated. Why do we do that? Because, your freedom ends at the tip of my nose. It certainly ends at the tip of my child's nose, and it certainly ends at the tip of every pregnant woman's nose, is that there are people in this country who are either too young to be protected, their immune system doesn't allow them to be protected, or other circumstances. And we live in a community where you can make a choice that could result in a child ending up in the hospital, that could result in a child dying, that could result in a child being either not being born or being deformed. That's why we have mandates, because we actually live in a community, and your decision, your quote unquote freedom, can actually harm people in your community.
This is a map here you have of vaccination rates across the U.S. Really interesting. Many states are below 95%.
Yeah, there are very few states that are 95 plus, right?
Yeah.
So, 1, 2, 3, 4, 5, 6, 7, 8, 9, only about 10.
New York is one of them.
Yeah. Yeah, so we got this little area here, like New York, Massachusetts, Connecticut, Rhode Island, Jersey.
Not Jersey, unfortunately.
No, not Jersey.
New Jersey is 90 to 94.9.
Yeah, not Jersey. Oh my gosh, Vincent, don't leave the city. Stay there. It's not safe. So, no, and this is really, this is a crisis, and it's not being addressed by someone who appreciates the crisis. Now, looking at the updates, we get updates from Texas. Over 400 of these cases, right, are down there. So 422 cases have been identified in Texas just since late January. Texas alone, we have 42 patients requiring hospitalization. New Mexico, we're up to 48. And basically, as we're seeing in all this data, it's a disease of the unvaccinated. But it's not just us, our friends in Canada, and they are our friends in Canada, despite what some people say otherwise. Between October 2024 to March 26, 2025, Ontario has reported a total of 572 measles cases. So this is associated with this outbreak occurring in 13 public health units. And that's just Ontario. But if you look around, Canada actually is starting to have a measles problem as well.
Do they have a vaccination problem in Canada?
All this, unfortunately, goes hand in hand. So.
All right, we're going to have to put some tariffs on those vaccinations then.
Well, maybe so that they can stay there in Canada and they can get vaccinated. Yeah. But no, what a disaster. Okay, and we do. We'll leave in. We able to successfully get that vaccine table recommendations from NYP. Okay.
So last week's update, I put a link to a picture image people can click on. So it should be in every week.
Okay. Yeah. So if you have questions, talk to your doctor. We're going to leave you that access so you can help figure this out, like what you need to do for your vaccination status. All right. Oh my, bird flu, or what were we going to call it last time? The U flu, EWE flu. I was working on these things. That was when it got in the female sheep. So the EWE flu. But cats tests confirm H5N1 avian flu virus in recently recalled raw food for cats. The New York State Department of Agriculture and Markets on March 28th warned consumers about the risk of H5N1 avian flu from savage cat raw chicken cat food. It just like the idea of savage cat branded raw chicken cat food. Okay. This is a California-based company recalled earlier this month following an investigation into cats that had contracted H5N1 infections after eating this food. And samples of the cat food from one lot were collected by the New York City Department of Health, tested by Cornell University, and were positive. Findings were confirmed by the USDA. So, all right, maybe a little bit of good news with the flu, right? We're still, if you look at the WasterwaterScan.org, they still are saying influenza A is at a high level. But if you start to look around the country, I am seeing lots of green. Green for minimal activity. Yeah, not New York. We're still high. So still keeping me busy here in New York, but most of the country is really starting to look a lot better. And if you look at ER visits across the country, really those flu visits are really coming down. So starting to see some light at the end of the tunnel there. And I'll leave in links for what are going to be the flu vaccine compositions for next year. Also, good news for RSV. We really are coming out of the respiratory season. RSV is still high in the WasterwaterScan.org levels, but the ER visits are really dropping down. We're really seeing that activity improve. And RSV is exciting, right? Because we now have an RSV vaccine. And so we got this nice article, Early Impact of RSV Vaccination in Older Adults in England, published in The Lancet. So in England, the UK Joint Committee on Vaccination and Immunization advised an initial program for those turning 75 years old with a catch-up to age 79 pending further data on protection of those who are older. So September 1st, 2024, vaccination of individuals aged 75 to 79 years began in England using the bivalent prefusion F vaccine. So that's the Abrysvo. So that's the Pfizer vaccine. They conducted an early assessment of RSV vaccine programs' impact on RSV-related hospitalization in older adults. Really impressive. I've got this figure in here where basically you're seeing what's expected, and then you've got this group that is in this vaccinated group, and about a 30% reduction in those aged 70 to 79 eligible for the RSV vaccine as far as hospitalizations for RSV. So really pretty impressive, right? It's an interesting way they show the data, right? Here's what we would have seen or what, following the line for that group. And then this really nice 30% drop in the folks that got vaccinated.
Yep.
All right. COVID.
This is a protein-based vaccine, right?
This is, yeah.
Okay.
Which is really interesting. So it is this bivalent prefusion F by Pfizer.
Yep.
Protein-based, not mRNA. We're going to talk about that soon enough. But showing this nice reduction. This is more of a traditional vaccine. There were those safety signals that we've talked about, but interesting enough, all those safety signals were really in South Africa. So I don't know what was going on with the South African part. But otherwise, we're seeing efficacy, safety data. All right, COVID. We are blipped a little back down to medium, and actually per the CDC wastewater, they actually have us at low, currently low. Percentage of deaths across the country is actually coming down, and I love our multicolored wastewater trend. What do you think, Vincent?
Yeah, we had a blip last week. You were all worried in what was it, the national. But I just think a bunch of people flushed their toilets at the same time.
I thought you were blaming spring break, all your students. You were, blaming the students.
That's true.
Yeah.
But now it's going down again.
Yep. So
spring break, students come back from home and they bring some COVID with them as well as other stuff. Yeah.
And maybe, on the spring break, they're all close to each other. They're breathing a lot, so. But yeah, no, that's going in the right direction. And actually, emergency department visits in the U.S. are also continuing to drop across the country. So encouraging there. But all right, let's talk about COVID active vaccination immunity. And I'm going to start with just a little bit of a story, just give people flavor of my day and my conversations about vaccines. So I'm sitting in the doctor's lounge at one of the hospitals, and actually it was this last weekend when I'm incredibly busy. And so, it's like on that show, The Pit, where you sort of reach the end of your day and you're getting a little kind of done with things. And there's this pulmonologist, and I think he just likes to torture me, Vincent. He makes sure that in every conversation he throws all like those key words, lab leak, vaccine issues, myocarditis, I don't even know why people bother to get vaccines anymore. And I'm just like, you're killing me.
This guy's an MD.
He's just torturing me. I'm pretty sure he's just torturing me. So of course I say to him, listen, I'm not sure what I did in a past life to deserve this. Because it always seems like when I sit down, people come and go, but they always leave the spot next to me open so this guy can sit down and torture me. But why are we doing this? Why do we keep vaccinating? So let's talk about this preprint. And this is preprint because, sort of hot off the press, so to speak. But this is a preprint evaluating the effectiveness of 2024-2025 seasonal mRNA 1273 vaccination against COVID-19 associated hospitalizations and medically attended COVID-19 among adults aged greater than or equal to 18 years in the United States, posted on medRxiv, right? So this is the Moderna vaccine, and this is looking at this season, looking all the way across the board. So this study evaluated the effectiveness of Moderna's updated mRNA 1273 vaccine. This is one targeting the KP2 variant, compared to those who didn't receive a COVID-19 vaccine this fall. And we'll talk a little bit more about that. So really just to give everyone context right up front, people have been vaccinated in the past, maybe they've had COVID in the past. This is really just, did you get an updated shot this fall or not? And what they're looking at COVID-19 associated hospitalizations and medically attended COVID-19 among adults 18 and up during the 24-25 season. So the data was extracted from linked administrative healthcare claims, electronic health records. It's where they get vaccinations from 23rd August 2024 through 24 December 24. They conducted a retrospective matched cohort study with propensity score weighting to adjust for differences between groups to assess vaccine effectiveness against COVID-19 outcomes. So pretty robust study. Overall, they've got 465,073 mRNA 1273 KP2 vaccine recipients, so folks that got updated Moderna shots in the fall. They're matched 1-1 to, they say, unexposed adults, so unexposed to vaccine. So they're matching 1-1 to folks that got vaccine versus folks that did not get a vaccine dose in the fall. The mean age was 63, with more than half of the population being 65 years and older. So really that group we're really trying to target here. Approximately 70% of the adults had an underlying medical condition, making them high risk for severe outcome. 30% did not. The vaccine efficacy was 52.8% against COVID-19 related hospitalization, and about 40% against medically attended COVID-19 over a median follow-up of 57 days, so about 2 months. The mRNA KP2 vaccine demonstrated significant incremental effectiveness in preventing hospitalization with COVID-19 and medically attended COVID-19 in adults during this season. So just to, as I sort of pointed out, maybe we'll have this cumulative incidence figure for folks to look out. This is COVID-19 hospitalization. You clearly see a separation with hospitalizations occurring much more often, well, twice as often, right? 50% reduction in folks that did not get versus did get the vaccine. So as I mentioned, most individuals in this study had gotten some kind of vaccine in the past. So this is really just looking at people that are staying up to date with their boosters, I will call it.
And this is a very small difference, though, really.
Well, let's talk about this, right? So that is kind of thing. So what numbers are we talking about? So, how many folks, and we're looking at October 1st to March 22, how many people with COVID-19 ended up, seeing a doc, right? So we'll talk about COVID-19 outpatient visits. So about 2 to 3 million. Mm-hmm. So if you can reduce the 2 to 3 million by 40%, right? That's kind of the way the numbers here. You're basically looking at a $1.5 million, million reduction in COVID-19 outpatient visits. And then if you look at COVID-19 hospitalizations, it's in the sort of 2 to 400,000. So sort of split the difference, say 300,000. You're talking about, avoiding 150,000 COVID-19 hospitalizations if people get a booster shot in the fall.
So this is good reason for people, 65 and over to...
Yeah, most of the people in the study, I think that's important, where, the majority of, so mean age was 63, but more than half of this population was 65 and over. So it's really this issue. If you're at risk of getting sick enough that you're going to end up to go see the doctor, or sick enough that you're going to end up getting hospitalized, you can actually reduce that with just getting a shot. This is on top of, this is getting a booster. So you get a booster, we might reduce the COVID-19 outpatient visits by 1 million. We might reduce those COVID-19 hospitalizations by 100,000 or 200,000.
All right.
But what I also put in here, I want to sort of compare this to, this whole, thing about, why bother getting vaccines? Like, I always return with, do you get the flu shot? What about the flu shot? And I think it's interesting. We had a really bad flu season this year. Mm-hmm. And we had not great uptake when it came to flu shots. So COVID, right, is kind of this year round. It's got this double peak. And here we're just talking about this winter peak, right? So our summer peak was worse, right, as we talked about. Now flu, we just have this winter peak. But how many flu illnesses? How many flu medical visits? Flu medical visits actually dwarfing, right? 20 to 34 million. It's almost 10 times as many medically attended flu visits as we had COVID outpatient visits. As far as hospitalizations for flu, 560 to 1.2 million, just in this winter season. And then flu deaths, pretty wide range because we're not really sure where that's going to fall in. But this was a pretty high. We're probably 60, 70,000 flu deaths this winter when we get final numbers.
And that overlaps with the COVID deaths, right? More or less.
Yeah, so it's really interesting. Yeah, right. So we're starting to see, and this becomes this issue. We have 18, 20% of folks got their flu shots. So really a lot of this, you say, oh, but the flu shot's only 40, 50% effective. Well, if you can take that 20, 30 million and drop it in half, if you can take that 500,000 to 1 million hospitalizations, drop them in half, you're talking about millions of people not needing to see the doctor. You're talking about hundreds of thousands of people not ending up in the hospital. Right. And you're talking about tens of thousands of people not dying of flu.
Okay.
So I'm encouraging people to get vaccines. Okay. But which vaccines? And this is a bit of an ow. Our listeners may have also heard this week that the US FDA missed the deadline for a decision on Novavax's COVID-19 vaccine. So, right, this is the traditional. This is, you maybe not so excited about mRNA or you had some reactogenicity or side effects. So this has been that protein traditional choice. The US FDA missed its deadline for making a decision on Novavax's COVID-19 vaccine. Senior leaders of the FDA said the company's application needed more data and was unlikely to be approved soon. The company, however, said it had responded to all the FDA's information requests as of April 1st. It believes its application is ready for approval. So the vaccine has been under emergency use since 2022, and it's basically waiting for them to get full approval. The one issue, and this is a big issue, is that the Novavax stocks that are currently out there, they're going to expire at the end of this month. So if there isn't some movement here, people that say, oh, I don't want mRNA, but I want to get the protection of a COVID vaccine, we may, again, we were told, oh, don't worry, we're not going to prevent people from accessing vaccines. We're about to lose access to this vaccine unless the FDA, which is under the HHS, does something about this. Okay. And I will leave the CDC COVID-19 vaccine recommendations up. And they still, just to repeat, we are recommending, and this is a public health across the board, children aged 6 to 4 years, they should get that initial series and then a yearly shot. Folks aged 5 to 64, that's 1 dose a year. Folks 65 years and older, or folks that have issues with their immune system, then it's a twice a year, right? So it's get a shot in the fall, 6 months later, you get a shot. So for a lot of folks, to keep that 40, 50% reduction in medically attended COVID and hospitalizations, probably getting about time for that second shot of this year. All right, and moving on to COVID early viral phase. So more on metformin, Vincent.
Won't go away. Huh?
So the article, Metformin Alleviates Inflammatory Response and Severity Rate of COVID-19 Infection in Elderly Individuals, published in Scientific Reports. And so I have to say, I think this is one of those studies where you really need to look closely to see what they actually found before you just sort of jump on the headlines.
So I remember the last time you reported on a metformin study, you said the differences were very small and you wanted to see more data.
Exactly. And so we had talked about the COVID out study that some of my colleagues had done. And this is this sort of complicated, you get acute COVID and you do this graded ratchet of metformin during the acute phase, and there were 4 different arms, and the people that got metformin compared to the metformin control group seemed to have, less issues and less long COVID, but they didn't necessarily have less issues and less long COVID than the other control group, so it was sort of muddied water. But it is this whole issue, is there some sort of anti-inflammatory effect of metformin? So people are still looking at it, and here, the study between 1st March and 2nd of July 2022, a total of 649,657 cases of COVID-19 infection were reported in Shanghai. Most were infected with the BA 2.2 variants. Of these, over 600,000, 413 were diabetic, and were used in the study to analyze the putative link between metformin treatment and the severity of COVID-19 infection. So these results are from this retrospective cohort study where they include 5,217 patients aged between 18 and 102, admitted to the North Campus of this particular hospital affiliated with Shanghai University School of Medicine. They analyzed whether there was a difference in a number of parameters in type 2 diabetics that had been on metformin prior to infection for, let's say, 3 months or longer, right? So this is not starting them. This is looking at folks that have been on metformin for at least 3 months versus folks that are not being treated with metformin. So they're going to look at some outcomes. They're going to look at risk of ICU admission, development of pneumonia, length of hospital stay, and they're also going to look at levels of IL-6, CRP, ferritin, lymphocytes, CD4 counts. They're also going to look at CT values. And they tell us, but we're going to go into this, they tell us there were no differences in age, sex, BMI, comorbidities, number of vaccines, kidney function, etc. So they do start off with this table, right? This is the table where you look at the total number, you look at the 121 that have been on metformin for the last 3 months, those not on metformin. They don't like statistically separate, but there are a few differences that I noticed. For instance, the non-metformin group, the A1C is almost a full point higher, sort of, not exactly matched, but not reaching statistical difference. But then again, you're only dealing with 121 and 292. A few other things, but just to sort of, a little bit of an issue there. Now, these are the numbers that jump out. So in the IC group, so the folks that the proportion of patients not receiving metformin was 92.5%, which is quite a bit different than the 69.2% of patients not admitted to the ICU. In the pneumonia group, so these are people with evidence of airspace disease, not receiving metformin, 78.6%, higher than the 67.2% in the non-pneumonia group. Compared with patients receiving no treatment with metformin, those receiving metformin had a shorter hospital stay, 12.1 versus 14.5. Big confidence intervals, right? Plus or minus 5.9, plus or minus 8.2. Now, in patients 60 years of age or older, those receiving treatment had significantly lower levels of IL-6. And significantly higher levels of lymphocytes compared with those not receiving treatment. But it's really interesting, and David can have our figures up for people. These differences are really seen in folks over 60. But I have to say, like you can look at these with me, Vince. It kind of requires a statistician to tell us they're different, right?
Yeah, for sure.
Yeah,
they have big, as you said, they have big plus minuses.
Yeah.
Right.
Big plus minuses, lots of overlap.
So these graphs, these are inflammatory and immune markers.
Exactly.
Right. They're very close.
Yeah. I mean, statistically, there's a statistical difference. I'm not sure how much of a, clinically, right? Because they're sort of suggesting that there's this correlate here.
Yeah.
But it's really, we're not seeing it unless you're over 60, so that becomes an interesting issue. But there are a number of limitations here, right? So maybe there's something here for folks over 60, but not under 60, right? That tends to be the folks that are asking me all the time about metformin, the folks under 60. We also don't know what dose of metformin they were on, and there is a difference between a diabetic that you can manage with metformin versus a diabetic who has an A1C of 8.6 and is on insulin, right? And I'm not sure it's the metformin that's the difference. It might be the difference that allows you to manage them with an oral med versus insulin. We also don't know what really happened exactly with steroids or antiviral drugs. So we're not sure if the patients on metformin or not were receiving the same other medicines, also other medicines that might not be helpful. There may have been some differences there. But, I have to say it's another interesting study. It's still very much basic science. It does build on animal experiments that show that metformin might inhibit the NLRP3 inflammasome activation, and that's based on a mouse model. Interesting stuff, but I think it may have gotten a little too much excitement.
These are people who are already taking it for diabetes, right?
Yeah.
if you wanted to treat people with metformin, you have to do a proper clinical trial, right?
Yeah. Yeah.
This is not a clinical trial. This is an observational, real world study, right? So you'd have to do dosing, first of all, because you may not, as you said, you don't need the same doses for diabetes as you do for COVID. So we're
Yeah.
not ready to say, here's a script for metformin.
Yeah, and I think that's what is happening is people are, they've got some sort of connect the dots, COVID, metformin, and there was that one study, but it's not just putting them on metformin; it's a particular dose escalation. So
I think if you're on it for diabetes, maybe you'll do a little better if you get COVID. But having diabetes makes COVID worse. So
yeah,
I don't know. It's a wash, probably.
and having a milder case of diabetes that you can manage with metformin, you may have better outcome than people with,
Yes.
A1C that are higher, requiring insulin injections, more advanced diabetes. So, and that's what I worry about. Is this a correlation? People who, yeah. Because people who don't have diabetes and are not on metformin at all, they do the best. So.
Yes.
So, all right. So number one, still recommended Paxlovid. Sort of interesting updated guidelines that are being bantied about locally is trying to use this more in the hospital instead of remdesivir. But this was the article, and it directly relates to probably why this is being discussed, is cost effectiveness analysis of nirmatrelvir ritonavir for high-risk individuals with COVID-19, a modeling study published in Open Forum Infectious Disease. This is where they really look and they say, okay, I understand charging over $1,000 for a script of Paxlovid when we had such a high rate of hospitalization and mortality. But now that we have lower baseline rates of hospitalization, the cost of Paxlovid probably needs to be reduced to make it actually cost effective. So that's a study out of Europe. Number two, remdesivir. Remember, first week, not hypoxic. That's 3 days. Once you get into the hypoxemia, moving into that inflammatory phase, and we're talking about 5 days. Molnupiravir, in some settings, convalescent plasma. And week two, the early inflammatory phase, the bad week when people really feel rotten, steroids in some context, anticoagulation, pulmonary support. And then, as we've talked, remdesivir if you're still within the first 10 days, or it looks like some folks that are requiring a high-flow nasal cannula, even more severe pulmonary support. Once the steroids have been started, there may also be a role of concomitant remdesivir. All right, COVID, late phase past long COVID. I've got just a few things here to wrap us up. So briefly, we have a preprint from the Recover Consortium. And I did hear that some of the Recover funding, long COVID funding, may have been restored. So we'll keep an eye on that. But we have the publication preprint, reinfection with, I guess we'll call it a posting. We have the posted preprint. Reinfection with SARS-CoV-2 in the Omicron era is associated with increased risk of post-acute sequelae of SARS-CoV-2 infection, a Recover EHR cohort study. Now, here we get the results from a retrospective cohort study using data from the Recover Consortium, comprising 40 children's hospitals and health institutions in U.S. between January 2022 and October 2023, a total of 465,717 individuals under 21. So we're talking kids, adolescents here. The mean age was 8.7. About half of them are male. Compared to first infection, a second infection was associated with a significantly increased risk of an overall PASC diagnosis, more than doubled, so a relative risk of 2.08, with many specific conditions, including myocarditis. That relative risk went up almost fourfold. Changes in taste and smell went up almost threefold. Thrombophlebitis, thromboembolism increased more than twofold. Heart disease, twofold increase. Acute kidney injury, twofold increase. Fluid, electrolyte, generalized pain, arrhythmias, abnormal liver enzymes, fatigue and malaise, musculoskeletal pain, abdominal pain, POTS, dysautonomia, and a number of others increasing across the board. So this This circles me back to that, what did I do in a past life colleague who always wants to know, why would anyone get a COVID-19 vaccine, particularly a child? Well, there's a really nice figure here because everyone is all focused on, I hear about this, 1 in however many thousand, they get a few hours of myocardial inflammation and then it resolves. Well, here you can see what happens when you are unprotected and get a COVID infection. And right now our kids are getting these infections once or twice a year. So here myocarditis almost quadruples and all these other. So really important that, if there was no COVID-19, we wouldn't need to vaccinate. But this is really trying to make a safer choice.
Oh, Daniel, just let it rip. Jay Bhattacharya, Great Barrington Declaration. Let it rip through the kids without knowing anything about this.
That is really the crazy thing to this day. Even when people write about things and they say, I think maybe we overdid it with COVID and the mandates and all the rest, and they keep saying like, but it really wasn't as big an issue in kids. We lost over 1,000 children who died from acute COVID the first 1 to 2 weeks. Thousands of children ended up with the inflammatory syndrome after COVID. Tens of thousands of children ended up hospitalized. So the only thing that, makes COVID mild in children is comparing it to adults. But children, hundreds of children should not die from an infectious disease in the current, time period. All these children, it's about 1% of them are not better 2 to 3 weeks later. They're still suffering. They're missing school. They're having problems. It's not just deaths with acute COVID, which is unacceptable. It's not thousands of people hospitalized, which is unacceptable. And it's all these kids who are not better months after that acute infection.
And he's rewarded with the head of NIH. Good job, Senate.
Is that really a reward, Vincent? It's just a punishment for the rest of us.
Yeah, it is a punishment for us.
So, all right. Well, we do have our friends up in Canada. So Canadian researchers led by McMaster University, which has an interesting track record, McMaster. What are they famous for, Vincent? Why do we know the name McMaster? What did they do up there?
I don't know.
Okay, maybe our emailers can remind us. I think they may have done stuff that, so McMaster University. They have developed the country's first comprehensive guidelines for diagnosing, managing, and treating post-COVID-19 condition or long COVID. And they have this plain language recommendations section. I'm going to say it's worth reviewing for clinicians, but also patients. And they have these nice sections, right? So they have prevention of PCC, post-COVID conditions, and a whole bunch where they go through recommendation strength and what are the recommendations. So interesting enough, prevention of post-COVID conditions, they're actually recommending using Paxlovid for prevention of long COVID. And they're giving this a recommendation strength conditional, another of other prevention recommendations. They are talking about testing, identification, and diagnosis of post-COVID conditions. They've got a number, and also in there, as we've discussed, that 10-minute standing test, that NASA modified lean test, and that also has a recommendation strength of conditional. They give recommendations here for pharmacological and non-pharmacological clinical interventions. So talking about antihistamines in folks with that MCAS type presentation, talking about other therapeutics for people with POTS and autonomic dysfunction. They even talk about where and when you might think about movement and exercise therapies. And they make a really nice point of basically saying we're talking about these people without post-exertional malaise, because post-exertional malaise is a situation where these approaches can actually make things worse. They talk about melatonin, good sleep habits, and a number of other do's and don'ts with good graded exercise. So I'll leave in a link for folks to take a look at that. And I will wrap us up with no one is safe until everyone is safe. Thank you for all the people that have stepped up and sent donations our way during our Floating Doctors fundraiser, which we're in the middle of, February, March, and April. Our plan is to double those to a maximum donation of $20,000 to help Floating Doctors continue to do the great work that they're doing down in Panama.
It's time for your questions for Daniel. You can send yours to daniel@microbe.tv. We only have 3 today because everyone's sending questions about measles vaccinations. go look at the charts and see if your question is answered. And if it's not, then write us, okay?
Okay.
All right, Brad writes, I was born at 59, my wife in 60, had measles as a child. My wife did not. She was brought up Latin America. Unclear if she received any measles vaccine. Because we were both after the 57 cutoff date where the CDC considers people immune and before 68 when the more effective vaccine became available, we would both be candidates. However, I receive infliximab, so I can't get an attenuated vaccine, but I did have measles as a child, so that's good. But my wife, I think she should get a MMR vaccine, but is there a meaningful chance that my wife could infect me if she receives the measles vaccine?
This is actually Brad, Christina. This is a good question here. So we have not seen that a person gets the measles vaccine and then they spread it to someone else. It is attenuated to the point where if your wife went ahead, she got the MMR vaccine, which the scenario you're describing makes sense, then there would not be a meaningful chance that you would end up getting infected.
Deborah writes, I have a question about measles vaccination. I'm sure I'm not the only person to whom this may be relevant. I'm one of many people born in the early 60s who may have received the weaker measles vaccine and are now 65 or older. So my understanding is I should get a booster now. Okay. As you might or might not be aware, chronic lymphocytic leukemia is the most common chronic blood cancer in this age group. Many of us are at the beginning stages of our cancer. I am. At diagnosis, we are told to not get any attenuated vaccines due to the hit our immune system will take. I am not talking about from cancer treatment, just from the natural, often slow progression of the disease. However, note the luckiest among us will never need treatment and will die of something else, like another cancer to which we will be susceptible or to infection. So my question is, for those of us who are not yet having symptoms and are on watch and wait for CLL, and not needing cancer treatment for it yet, is there a situation some of us might have with low CLL numbers in our blood and not that much else abnormal that we can safely still get the measles vaccine as a booster? Better to get it now when my immune system is still relatively healthy than to wait until measles is in my community and I'd have to isolate for the rest of my life, never get on a plane or have a vacation or fly to see my grown children and future grandkids. How much risk would there be to getting the vaccine ASAP? Is there any guidance from infectious disease about what to measure to see if my immune system is healthy enough?
Yeah, so Deborah, this is a great question, and this is one of those where, well, I'll talk a little bit about it, but the ultimate punchline is going to be talk to either your CLL doctor, or better yet, I'm going to recommend talk to an infectious disease doctor about this. Yeah, so CLL, very familiar with this. I actually published a paper with Conti Rai on this a number of years back. And CLL can impact your immune system. But as you point out, there's a whole gradation of CLL. Most people die with CLL, not from CLL. And so, this black and white, you have CLL, you can't get a replication competent vaccine. It's not that black and white. You can actually look at the degree, the severity of the CLL. I remember there was actually a Conti Rai staging system, which has been supplanted in recent years. But you can actually look at the CLL severity. And I would actually recommend seeing an infectious disease doctor, having them kind of look and help guide you through this. Because, the CLL is, potentially going to progress. We are changing our world here in the U.S. to one where we're seeing measles all over the place. And so if there is still a window here when it might be safe to get that MMR, now is probably the time to have that discussion.
And Susan has a question about Zika. May 30th, my pregnant daughter-in-law will be vacationing in Bermuda for a few days. She'll be 27 weeks. Do you know if Zika or other infections that could impact her pregnancy are a concern in Bermuda? I don't see information on the CDC site, but with the ongoing attempts to weaken CDC, I didn't expect it to have current information.
Yeah, so this is one of those issues where, the CDC has historically been pretty good. Right now, I don't believe there's any evidence of ongoing significant Zika activity in Bermuda. but let's see, May 30th, she's going to be vacationing. I hear your concerns, and this is, I think, shared by a lot of us. Like, will we still be able to go to that CDC site in 30 and check and see if there's any travel advisories, or is the information just not going to be there? The staff not there, the librarians not be there, the journals not be there, everything else we're seeing. So, I would reach out. To your doctor. There still are some commercial sites out there that are trying to keep track of things. The TRAVEX and some of the other travel providers. You might be able to get a little bit more information as you get closer to that May 30th.
As of now, Bermuda is Zika free.
Yeah.
That's TWiV Weekly Clinical Update with Dr. Daniel Griffin. Thank you, Daniel.
Oh, thank you. And in these tough times, everyone, be safe.